And thanks, Min, for getting all of this set up. Um, as an alum of the college, I'm excited to be here. I think today, I talked with Caitlin and Min a little bit about sort of the exposure you guys have had with, to the vaccines in school. And I think the hope for today is to sort of arm you with the tools to you are able to reassure your patients, families, coworkers, and then to combat vaccine hesitancy in general. So we'll be talking about a little bit the vaccine development, briefly talking about mRNA technology, diving into the two approved vaccine candidates, and then finishing up with trying to establish a little bit better understanding of the variants that are currently circulating. So with that, we can get started here. So no doubt that the timeline for the development of vaccines during the pandemic was drastically different than everyone's previous experience and what they expected. And it's unfortunately often used as a way to convince people that the vaccines might be unsafe. And so this slide talks a little bit about what was different this time around. And primarily in the beginning, there's generally this design and exploratory phase that can take years, a lot of animal studies, things like that. And we really utilized our knowledge that we gained from the SARS and MERS coronaviruses and their outbreaks. And so the discovery phase was pretty much omitted and existing processes were adopted. And so we were able to start, the phase 1 and phase 2 trials almost right away. And so that cut years immediately off the timeline. And another thing that you'll notice here is that in the traditional pathway here, a lot of these clinical phases are running in sequence, as opposed to in the pandemic here, a lot of these are running in parallel. And so rather than waiting for all of the phase 1 studies to be done before starting phase 2 and phase 3, respectively, a lot of those are running in line with one another. Vaccine manufacturers also, because of the urgency of the situation, had already begun large-scale production. So I think we heard a little bit about this in the news, back in, the summer to fall of last year, that the vaccine manufacturers are going to have millions of doses ready after the approval. And so that's really at their own risk. And I think is a testament to their understanding of the urgency of the situation, but certainly cuts down a lot on the time that's needed to distribute the vaccine. So you'll see this POE throughout the presentation, and it stands for point of emphasis. And these essentially are salient points or high yield points that are either the topic of conversation, rumors, myths, and things like that. And so one of those in relation to this is that the vaccines were hurried at the cost of safety, and I think this just is part of the puzzle that says no, that's not the case at all. So prior advances in mRNA technology, which isn't new, it was developed in the 1990s, set us up for success this time. And some of those things are things like taking advantage of computer-based technologies that allow testing of several different mRNA sequences, things like that. And also down to the production level where, there's no live pathogens that need to be contained. Everything can be done in a standardized fashion in a single facility. And so a lot of these things represent distinct advantages for mRNA technology that favored this quicker development process. To further emphasize that safety has been a priority in the rollout, this slide shows some, not all, of the surveillance programs contributing to gathering safety data post-emergency use authorization. So I think we're all sort of familiar with VAERS, the Vaccine Adverse Event Reporting System, and this is a form of passive surveillance. In other words, we're simply reporting, or we're required to report adverse effects to the VAERS system. But other examples of that would be this BEST program. The CDC has a couple of different programs, the Safety Data Link, the Safety Assessment, And then NHSN and the Centers for Medicare and Medicaid Services also require some reporting, and will be reporting some safety data as well. New to the pandemic vaccination effort is this method of active surveillance. In other words, soliciting or reaching out to people to see how they're doing, not just relying on those reports passively coming in, and the system called vSafe. So vSafe is, fairly easy to sign up for. Certainly not everybody has access to smartphone and things like that, which, that has to be taken into context, but certainly more safety information is better than not. And so combined, this forms an impressive network of monitoring for safety issues afterwards, and really reinforces that safety is a priority. Briefly, I just wanted to touch on the public health considerations with regard to rollouts of the vaccine. This picture from an artist in the Seattle Times pretty much says it all about our distribution in most places thus far. Unfortunately, I think we could be doing much better with regard to equitable distribution. A lot of our health departments and healthcare systems are using intranets like MyChart or their websites to get people enrolled, and the fact of the matter is a lot of people just don't have access to that technology. And so are some of those people getting left behind? And the answer is probably yes. So it sounds like you guys might have been introduced a little bit to this, but so we'll just briefly go through it, as there is a point of emphasis here in terms of a myth that's sort of going around. So the first step of creating the mRNA vaccine is to produce the mRNA from a DNA template. And that DNA template is either entirely synthetic or it's produced by bacteria, most commonly E. coli. But there are no human fetal cells or any other exotic types of cells that would cause ethical or religious objections. And so once that is created, we have a cell-free transcription reaction that occurs in a test tube to create our mRNA target. And this will eventually be carried into the cell. The mRNA vaccines we will be talking about are enclosed in what they call a lipid nanoparticle, but several different carriers have been studied, and even mRNA without any surrounding lipids can elicit immune response outside of the cell. But it seems as if this lipid nanoparticle and getting the mRNA in the cell obviously results in a much more significant immune response. So once it's inside the cell, the lipid nanoparticle coating is degraded, and then the mRNA floating in the cytoplasm is sensed by a particular set of essentially toll-like receptors that ultimately result in the cytokine release and further propagation of the immune response. And then a lot of that mRNA gets to the ribosome, where it produces that protein of interest, in our case, the spike protein. It's important to note that in the upper right, mRNA never leaves the cytoplasm, and so it doesn't have a way to get into the nucleus. And so there is no way for the mRNA vaccine to alter the host DNA. And so that has been a myth that has been circulating as well. There have been some additional concerns that HIV positive patients may be able to convert the mRNA in the cytoplasm to DNA because HIV contains a reverse transcriptase. We don't have any data to suggest there's a risk to that, though there haven't been, unfortunately, a lot of HIV positive patients in the phase 3 trials. But a lot of the very smart molecular biologists tell us that's very, very, very unlikely to happen. So this slide is mostly for your reference, but there's a couple of significant points on here to highlight. First is the number of doses in the vial. So if we are using low dead space syringes and needles, very little volume gets caught in the hub of the needle. And so we can fairly reliably get 6 or sometimes even 7 doses out of the Pfizer vial. which is up from the original authorized 5. Likewise, Moderna has been granted clearance from the FDA as of last week to increase the number of doses in their vials from 10 to 14. And this doesn't necessarily seem like a lot, but on a scale of millions, 40% more will make a big difference in that. Next thing to highlight is in red here, the polyethylene glycol. Each formulation has this, and it is one of the leading suspects for causes of anaphylaxis in vaccine recipients. And because of that, the FDA has issued warnings, especially for patients who have had severe reactions to injectable polyethylene glycol in the past. We do encounter PEG on a regular basis in food and a lot of other substances that we ingest, beverages, things like that, on a daily basis without generally any issues. So they're really focusing on those people that have had issues with the injectable PEG formulations in the past. And then the last thing to talk about here would be the ultra cold supply chain. This has served as a big logistical barrier in terms of getting these vaccines to where they need to be. Just a couple of days ago, Pfizer submitted some data to the FDA to change the recommended storage to be much more similar to Moderna, so -15 to -25. So it'll be unclear if they do approve that or not, but that would certainly help in some cases for those facilities and regions that don't have those super ultra cold freezers. All right, so let's dive into the Pfizer vaccine. We're going to be focusing primarily on the phase 2/3 study that led to the emergency use authorization, but I think briefly noting how we got here can be a little bit enlightening. So, the phase 1 studies are often dose finding and tolerability. They actually had another candidate that was named pretty much the same thing, B1 instead of B2. It elicited a very similar immune response. You can see that how they stratified the patients down here in the phase 1 study to receive different doses of the 2 different candidates. And ultimately they went with the B2, BNT162b2, to the phase 2 and 3 study. Even though they elicited similar immune responses, that second candidate was much more tolerable. So here's sort of the structure of the phase 2/3 trial that led to the approval. It was international, multi-center. They were randomized to either receive the vaccine candidates in a 2-dose regimen, 21 days apart, or placebo. They were further stratified based on their ages. And it should be noted that they did include 100 patients that were 12 to 15 years old, but they were not included in the analysis. The median follow-up time at the time data was submitted to the FDA was 2 months. And while we care about everyone, perhaps we care a little bit more about those who are at risk for severe disease and thus death. So below you can see the breakdown of participants with high-risk conditions that completed 2 injections. So 45% of the vaccine group had a high-risk condition, which this is outside of age, which certainly seems to be a risk for severe disease as well, but and 44.6% of the placebo group. So those were comparable between the 2 groups, which is good. Demographically, here are some notable trends that may to some degree limit the widespread generalizability of the information. First, 83% of the patients were white, which thankfully is not reflective of the entire country. We're much more diverse than that, but unfortunately, other ethnic groups have been disproportionately impacted by the virus, and so ideally we would want a larger proportion of them in the study. Next, the baseline seropositivity. So only 3% of the patients in the study had evidence of prior infection with COVID-19 or SARS-CoV-2. So really our ability to reach definitive conclusions on people in that particular population is a little bit limited. And then as we mentioned on the last slide, a good portion of the patients in this sample have comorbidities that place them at risk for more severe disease. And so every time we look at a study, we want to look at some of these trends, looking for what they call external validity, is how generalizable are these populations to the population that I'm interested in. So in terms of the clinical data, so vaccine effectiveness in preventing confirmed COVID-19 from 7 days after dose 2 was the primary thing that they were looking at. Anytime you're looking at these studies, you'll see the word case. And this is essentially, this will vary from study to study, but it describes what they consider to be a COVID-19 case. And so this can vary a little bit between studies. The case definition for this study is laid out there. And I think when we look at the vaccine efficacy, they found 95% here. It's helpful a little bit to talk what that means. So it doesn't necessarily mean that 95% of the population is protected. It means of those that we think would become infected, in the background rate of infection, the rate of infection in the placebo group, 5% of those, only 5% of those will become infected after receiving the vaccine. So essentially what the vaccine efficacy is doing is it's looking at the rate of new infections in the vaccine group and the rate of new infections in the placebo group and comparing them to get that 95% number. Likewise, this endpoint includes participants regardless of their baseline evidence of prior COVID-19 infection. So the previous outcome was just people without previous infection, and this is people with or without evidence of previous infection. And so this seems like it's probably a little bit more representative of the real world population. I mean, we have lots of people out there that have had COVID before. And it's also important here to look at the population being studied. So they call this the evaluable efficacy group. And all of those patients in the evaluable efficacy group had received both vaccinations within the predefined window and had no major protocol deviations. So again, these are ideal conditions. So as you probably are all aware, one of the big reasons why antihypertensive doses go up is because people don't necessarily take their medication every day. And so we can't, in the real world, expect everyone to follow the quote unquote protocol as we would like them to. And so you'll hear the word effectiveness instead of efficacy being thrown around. And effectiveness essentially refers to how well does the vaccine work in the real world under, quote unquote, real conditions, and not just ideal conditions. But nonetheless, a very good vaccine effectiveness there as well. And this is in preventing severe COVID-19, which they defined as meeting the prior definition and then one of these conditions here. So looking through these are obviously very important patient-centered events. We care about when these happen to people, not only because these are very bad for the person that has it, but also because these are the people that are going to be hospitalized and taking resources, things like that. So I think this is a very important outcome that we need to look at with regard to these vaccines, is how likely are these to keep people out of the hospital, keep people from dying? Because we see with a lot of coronaviruses, especially like the seasonal coronaviruses, that we don't always, immunity from that doesn't always prevent infection from the virus, but it does prevent disease. And so I think that's sort of, our goal should not be to eliminate all infections altogether, but how can we reduce the severe disease? And so the vaccine appears to have a really good efficacy in terms of preventing this severe disease. All right, so this is the same group as before, looking at severe, except this time we're looking at prevention of confirmed COVID-19 after dose 1. So this is a big point of contention now in the media, being that the distribution of vaccine hasn't gone tremendously well. The question being, can we get away with a single dose, or vaccinating more people with one dose versus saving that second dose for the people that have already had one dose. And so it's important to note right off the bat that no single dose arm was studied. So that would be the ideal situation, is that we would know of people who got just one dose and follow them into the future in the same duration as the people that got 2 doses. But we're sort of limited to that because everybody got the second dose. And so our follow-up duration is limited until they got that second dose. And as we see here, after your primary immune response, so your first dose here, you do develop some antibodies. But after our second dose, our second exposure, those level of antibodies increase dramatically, very, very quickly. And so when we look at the table that is looking at dose 2 to 7 days after dose 2, I mean, there's probably a lot of impact from dose 2 already in here because it's that second exposure and those antibodies are already skyrocketing. So really we're limited to 20 days or so of follow-up for these patients, which is not enough to definitively say that we know whether or not one dose is enough. And so the point of emphasis down here is sort of what we just talked about, that there's some suggestion that those with previous COVID-19 infection may only need one dose as well. And so in this situation, the prior infection would serve as the primary immune response. And then the first and single and only dose of the vaccine would serve as the secondary immune response. And so I think the theory has some merit because it does theoretically make sense, but we just don't have enough data to suggest that that strategy is acceptable right now. So there have been some studies super recently within the last few days that had come out of Canada saying that the single dose is about 92% of effective, and then one out of Israel that said that a single dose is about 85% effective. And nothing has changed with regard to this first one, where they essentially reanalyzed the data from that we just looked at, and did some fancy math to try and tease out that maybe the first dose is more effective than we think. The Israeli data, they had a little bit more follow-up and things like that. So that is definitely encouraging, but it's just not enough still. And so we still have this conundrum where there's that difficult decision of, do we vaccinate more with the single dose, or do we continue with the recommended 2-dose regimen? And that decision is going to be further complicated by the variants that we'll talk about in just a little bit. So this curve essentially shows in the red the number of cases in the placebo group, and then in blue the number of cases in the vaccine group. And the big takeaway from this is that cases appear to occur at similar rates until about day 14. You can see the curves sort of diverge, maybe day 10 to 14, somewhere in there. And so we will see people acquire COVID-19 after vaccination. It will happen, not only because 95% is not 100%, but because protection doesn't happen immediately after you get it. It takes time. And so we have to be very careful about people jumping to conclusions about how the vaccine is not effective, things like that, because somebody got COVID-19 in between dose 1 and dose 2. So again, we care about the people who are at risk for severe disease. And this table looks at patients with comorbidities that put them at risk for severe disease. And it looks like the vaccine works just as well in these patients, which is a welcome and encouraging finding. Note that the numbers here for the number of people that have comorbidities are a lot smaller than the total sample, and so we still have that short duration of follow-up. So encouraging, but we do ideally need more data to be super confident in that. And then we do have important missing and groups that aren't incredibly well represented, such as those who are truly immune compromised, like transplant patients, pregnant women, which we'll talk about, there was a very small number of patients that had evidence of prior COVID infection. And so ideally, we would want more information on those children. And then in this particular study, minorities disproportionately impacted by COVID-19. It would be really good to know a lot more about those and what might, how well these vaccines work in those vulnerable populations. So in terms of the safety monitoring plan up above, I think it's just important again to stress that safety has been a priority. They have a very complex, well thought out safety monitoring plan. Adverse effects that led to discontinuation were similar in both groups. And there's some recent VAERS data that suggests that these are very safe. So 91% of VAERS reports after about 14 million doses were non-serious in nature. Now, this next point about deaths, VAERS received 113 reports of death, after COVID-19 vaccinations, consistent with background rates of all-cause mortality, with no signals to suggest. So this is a huge point of emphasis that there are deaths that occur every single day in the U.S. under normal circumstances, and so in 2019 that was almost 8,000 people a day that are dying. And so we're going to have coincidental timing with regard to vaccination. So we will have people dying shortly after vaccination. And I think it's important that we reassure people that people are going to die from these things anyway. I was surprised by the fact I didn't know that it was 8,000 people a day. That's a lot. And so we have to be cognizant of the fact that this is happening no matter what we do. And just because somebody received a vaccine, it's much more likely to be a coincidence than linked to the vaccine. Additionally, I encourage you to be skeptical of claims of long-term or coincidental events being attributed to the vaccine, not only deaths, but certainly things like autism or rare diseases that have an onset of months or years after vaccines. Combing through the VAERS data, you'll see that nearly all serious adverse events potentially related to vaccines occur within 30 to 45 days. And we're talking the vast majority, so like over 95% of these. So it would be really strange for somebody to develop a serious, significant adverse event that far out. So we need to be able to speak to that and to reassure people that that's not something to worry about. So in terms of adverse effects, without a doubt, people are going to get injection site reactions. We know that to be the case, and I'm sure a lot of you have firsthand experienced that, as I have. So a really large proportion of patients will get these. And a lot of people will get these systemic side effects as well. And most of these are due to what they call reactogenicity. And you will need to explain what this means to your patients, in a friendly way. So, come up with a way of describing it, practice it, make sure that you have it, down in your head so that when you're explaining these to your patients, that it's in a way that they can understand. So, most commonly we explain it as, this is your immune system reacting to the vaccine and starting to develop immunity, something to that effect. The good news is, despite a good chunk of people experiencing symptoms, very few had severe symptoms, and the symptoms only last about 24 hours after onset. And you can see that the incidence after dose 2 is much higher than the incidence after dose 1. So we can use these trends to inform our patients about sort of what to expect after their vaccines. Something that has come up in the media recently is concerns about taking antipyretics, namely ibuprofen, but certainly Tylenol too, after the vaccine for symptoms due to reactogenicity. And there's some very minute evidence on pre-treatment with other vaccines in children. And so I think somebody got a hold of that, and it circulated through the social media and things like that, and got a little out of control. So there's there is the possibility that perhaps blunting the fever preemptively theoretically could potentially maybe impact the extent of the immune response. And so I think it's reasonable not to routinely suggest pre-treatment right now. But there's nothing wrong with taking Tylenol and ibuprofen after, when you're experiencing symptoms, in order to make it more tolerable. And for those patients you have that have osteoarthritis and are taking scheduled Tylenol or whatever it might be, you should encourage those patients to continue taking their Tylenol and their ibuprofen, scheduled or as they normally would, uninterrupted. Because really, we don't have data to suggest that that's an issue, and certainly their quality of life is important to us as well. So moving on to serious side effects, anaphylaxis is one that we certainly care about. It is life-threatening, but luckily it's treatable. So based on nearly 10 million administrations of the Pfizer-BioNTech vaccine, there appears to be a low rate of anaphylaxis at about 4.7 events per million vaccinations, which is fairly comparable to influenza, and much, much, much less common than anaphylaxis due to penicillin, which is 1 to 4 events per 10,000 administrations. Most importantly, this is treatable. All the vaccine sites are prepared for this. They have plans, they have epinephrine on site, and there have been 0 deaths as a result of anaphylaxis up until this point. And remember, we're monitoring people for about 15 to 30 minutes after they receive the vaccine. Median time to onset was about 10 minutes. So we really should be catching the vast, vast majority of these people in the clinic if they are going to develop this complication. Bell's palsy does come up. There were 3 occurrences in the vaccine group and none in the placebo. Again, thinking about background rates, would this happen anyway if the patient didn't get a vaccine? This is consistent with the expected background rate in the population on a yearly basis. So in addition to that, I think there's a fair amount of evidence that suggests that Bell's palsy is probably due to the herpes simplex virus. And so it's really difficult to establish causation with the vaccine, especially being that it's occurring just at a rate that we would normally expect it to. Appendicitis for the Pfizer vaccine was the most common serious adverse effect in the vaccine arm. There's really no plausible reason to think that this represents a vaccine-related risk. And again, this is probably going to happen anyway. And so there were really only 2 serious adverse effects that the FDA thought were likely related to the vaccine, outside of those reporting, severe fatigue, things like that. And one was a shoulder injury likely related to administration technique. So it's a good lesson to remember that if you are vaccinating people, that making sure that you're not up near the shoulder joint, because if you can certainly injure the joint if you inject into that space. And then a lymphadenopathy that involved an armpit lymph node near the vaccine site. So those are really the only 2 serious adverse effects that the FDA thought was likely related to the vaccine, outside of the severe reactogenicity reaction. So this is incredibly encouraging. I think I don't know what more we could ask for. And then certainly, with the Bell's palsy and things like that, we're going to be watching that closely. The FDA is obviously aware of that, and we'll be keeping an eye on any additional cases that occur. So for Moderna, again, we'll primarily be focusing on the phase 3 study, though Moderna went through very similar phase 1 and phase 2 studies to determine which dose is most appropriate, and how robust and safe the vaccine is expected to be. So the Moderna vaccine only took place in the United States, but it happened at 99 sites. They were also randomized 1-to-1 to receive the vaccine candidate in a 2-dose series, 28 days apart, or a matching placebo. They were further stratified into groups based on age and or risk factor for disease. So this is slightly different than the Pfizer study design. Note that there's much lower percentage of patients with high-risk conditions as compared to the Pfizer and BioNTech study. So only 22% or so of the vaccine group and 22% of the vaccine group. So it's good that they're comparable, but much less than anticipated in terms of how many patients have comorbidities and how many are at risk for severe disease. So that is something to keep in mind here. Looking at the demographics in a similar way, all of this occurred in the United States. Nearly 80% were white. A very small percentage of them had evidence of prior infection, smaller amounts of comorbidities. So again, this population seems to be a little bit less diverse than, with regard to risk for severe disease than the Pfizer group, and probably limits the generalizability a little bit. But obviously it's still very important data. So again, the case definition, as I mentioned, varies from study to study, and it does in this case. But overall vaccine efficacy in this particular endpoint is 94.1%. So very, very similar to Pfizer's 95%. And now remember, the population that we are studying also matters. So this, like the Pfizer, is, they call it per protocol, and it's people that had negative baseline, evidence for previous infection, received both doses on schedule, and had no major protocol deviation. So really, we're emulating ideal conditions here again. So especially with the fact that there's no people with evidence of prior infection in this group. So these are just things that you'll have to keep in mind when you're interpreting this data. All right, so much like the Pfizer study, the severe COVID-19 includes meeting the case definition of COVID-19 plus one of the following. And again, if we shift our goal from preventing infection altogether to preventing people from becoming severely ill, needing hospitalization, being exposed to all of the hazards that come with being in a hospital, potentially dying, perhaps these vaccines look even better. For example, this vaccine efficacy of 100% in preventing severe COVID-19. And this outcome is important as it helps us assess, disaster preparedness, public health. With the results, we can fairly confidently say that a vaccine like this and like Pfizer's will help our healthcare system from being overrun by critically ill patients that take up spots in the hospital, resources, expose healthcare workers, all of those things. And so that is this wonderful welcome news that we don't want to relive what happened in the spring, that's for sure. All right, so this is what they call an actual modified intention to treat analysis, meaning that this includes all patients that had received one dose. So that includes some that haven't received the second dose yet. And again, this demonstrates that there is likely some appreciable level, they say 80.2% vaccine effectiveness, of protection after one dose. But the extent of which we can understand that protection is limited by the follow-up duration and the small sample. And thus, we still don't have enough information to suggest that one dose, would provide sufficient protection for everyone, especially when we take the variants into account. And it stresses again that if we are potentially going to prioritize first doses for as many people as possible, for example, most of the people above 65 years old versus saving the second doses, we have to be intentional about that and have the data to back that up. Down here in the severe, I think this really demonstrates how quote unquote fragile some of the data is when we get to small numbers, because this looks really bad, right? 42.6% for preventing severe COVID-19 after one dose. And I think being that with two doses, it's 100%, we would expect it to be better than 42% in it. And it probably is. We just get down to these very small numbers. And both of these cases in the vaccine group met severe criteria due to a oxygen saturation less than 93% on room air. So perhaps even a soft call for severe disease. But so I think it's probably better than this, but certainly it's a good example of how the data can look drastically different just because of small numbers. So just like the Pfizer vaccine, you can see here that the rate of cases occurs at about the same until about day 14, 10 to 14 after dose 1. And so we run into that same situation where we have to be able to speak to the fact that people will get COVID-19 after vaccination, especially within those first 2 weeks after dose 1. And being cognizant of the fact that 94.1% is not 100%. So people will still get COVID-19, albeit less severe, after 2 doses of the vaccine. So now looking at those at high risk for severe disease, this is really good news that in this column here we have vaccine efficacies all above 91%. And this is great news, especially, but when we stratify into some of these groups, you can see these numbers. So there's only 80 patients with HIV, 93 with liver disease, 600 and some with significant cardiac disease. So these are a lot smaller numbers, and the duration of follow-up is still short enough where we're going to have a hard time drawing super definitive conclusions based on this, and we need more data. And much like the Pfizer study, we're missing truly immunocompromised people, pregnant women and pediatrics. All right, so basically here we looked at people with, regardless of their baseline COVID-19, prior infection status, and it looks like it works really well in that population, and part of that may be due to that, that secondary immune response that the vaccines provide for these people that have already had it. But some reinfections have been documented in the literature, and so this is really encouraging. Again, they have safety monitoring plans that are very complex, well thought out. With the Moderna, very similar rates, actually less discontinuation from the protocol in the vaccine group than the placebo group. And again, be skeptical of those long-term coincidental events being attributed to the vaccine. Very similar to the Pfizer group, although Moderna might have slightly more side effects due to reactogenicity, and that may be due to the fact that they used a higher dose of mRNA, the 100 micrograms versus the 30. Again, look at these trends, be able to use these to help inform your patients about what to expect. Very low incidence of severe effects in all categories, and the effects don't really last that long. Serious effects for Moderna, an even lower rate of anaphylaxis, 2.5 events per million vaccinations. Bell's palsy was, there were 3 cases of Bell's palsy in the vaccine group in the Moderna study as well, and 1 in the placebo group, same thing. Difficult to establish causation, happens at around the background rate. There were a few cases of facial swelling or angioedema. All 3 cases had a history of cosmetic dermal fillers prior to vaccination. They all did just fine, but it is probably related. There has been some reports of this happening after an influenza-like illness, even just a natural viral infection. And so we think that might actually be related. And much like in Pfizer, the FDA really found almost none serious adverse effects that they thought related to the vaccine outside of those severe reactogenicity symptoms. And really the only one that was not a case of facial swelling due to cosmetic dermal fillers was a case of intractable nausea and vomiting. So this is super encouraging news. So as we saw looking at the data for both vaccines, there were almost no pregnant women. So this is a huge point of emphasis. Data from the CDC demonstrates that symptomatic pregnant women are at increased risk for hospitalization, need for intensive care. And so the question is, what do we do with the pregnant patients? How do we present this data to them. And so there's a couple things that we can reference. First, preliminary DART studies. They're essentially animal reproductive studies. So were submitted by both Pfizer and Moderna. And they don't indicate any risk to female reproduction, embryo development, or postnatal development, so birth defects. So that's great news. A lot of pregnant women have, including a lot of the coworkers that I work with, have chosen to get the vaccine. And so, with the V-Safe tool, things like that, we'll be expecting more and more data to come out around those pregnant patients. And Pfizer is conducting a placebo-controlled study in about 4,000 pregnant women who are pregnant between 24 and 34 weeks of gestational age. They haven't started enrolling, but should be soon. So, really, in the meantime, all we can do is present our pregnant patients with the information that we have, noting that both the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine both recommend pregnant women be offered the vaccine. There's no reason to think that it would be unsafe for them. It would likely protect the fetus from COVID-19, especially if they're breastfeeding. There's been some data to suggest that those antibodies cross into the breast milk. And so the risk of COVID-19 is probably much worse than the outcomes, that may, the temporary discomfort pretty much is what we would expect, as with anybody in pregnant women. So I think in the meantime, the approach that I've taken is more of a shared decision. So presenting them with the information, and ultimately letting them make the decision, but certainly encouraging them to do so, just because we know that there's a definitive risk of bad outcome from COVID. All right, so we'll finish up with the variants here. So, most RNA viruses, including SARS-CoV-2, don't have a proofreading function. And so they are subject to transcription errors, which we call mutations. And this is a double-edged sword for them. It allows them to, adapt to their environment much more quickly. However, they also run the risk of, mutating to the point where the translation of the protein is stopped completely, and that's something that was essential to, for them to replicate. And so then they just die off, basically. So, from a public health perspective, some of the mutations are clinically meaningless. They change one amino acid for another, might change the conformation of the protein a bit, but it doesn't really affect how the virus acts. However, some might, as you'll see, influence infectivity and how severe of disease that it causes. So the D614G mutation occurred early on in China, which was found to cause increased infectivity, so much more easily spread. That subsequently spread throughout the world, becoming the predominant variant. So in a lot of these things that we'll be looking at, the D614G is considered the quote unquote control or wild type virus. Primary concerns regarding mutations in vaccines are changes in the spike protein, its conformation, and the ability to evade neutralization by antibodies. Luckily, mRNA vaccines are, advantageous where, a lot of the things we talked about before, we're able to change those quickly, produce them quickly, and we should be able to respond to those if we need to. Unfortunately, the US has not made genotypic surveillance a huge priority, and I think the biggest reason is cost. It's an estimated $2 billion to sequence just 15% of the confirmed cases in the US. So that's a hefty price tag. But I think the government recognizes that this is probably more important and it deserves more resources than they have allotted so far. February 10th, House Democrats proposed almost $2 billion for sequencing and tracking. So we'll see if President Biden signs that next month. As far as logistics, it is challenging. The CDC is in charge, but they have to use this patchwork of their labs, local and state health departments and private sectors, to really meaningfully look at all of these variants. And so that's no small task, but I'm glad that that's becoming a priority. So moving into the individual variants, B117 likely originated in the UK, in over 80 countries worldwide now. It's probably going to become the predominant variant here in the US by March. Luckily, data suggests the efficacy of the vaccines are not meaningfully affected, but the UK did report a small number of B117 that had developed a mutation that is a little bit more worrisome, that's carried by some of the other circulating variants. And it's worrisome because it might be able to escape some types of antibodies that are generated by the vaccine. So, we have B117 that's more infectious and carries a higher risk of death. And hopefully, we can avoid, the widespread proliferation of this virus with this variant with the concerning mutation that can evade antibodies. So in looking in how, and how to assess how these variants affect the vaccines, they take human serum from vaccinated people and introduce a virus with the modified spike protein. And they look at the neutralizing antibody levels that are generated. And so here we can see that here's the wild type, in all of these here. And in the middle, you can see the D614G, that's the wild type. And then a slight decrease, a 1.2 times decrease in neutralization antibodies, a 1.8 times decrease in neutralization antibodies here. And so it seems that, the primary mutation, the N501Y in the B117 variant, doesn't seem to affect the level of protection offered by the Moderna vaccine very much. And, the fact that there are some samples with the E484K mutation is concerning, as we'll see on the next slides. So for Pfizer, similar, there really isn't that big of a reduction in the level of protection offered by the vaccine. None of these samples include viruses with the E484K mutation that is thought to be able to evade antibodies. So B1351 is the origin in South Africa. This is one that we are definitely watching and concerned about, because it does feature that E484K mutation, which might help the virus evade some types of antibodies. There is no evidence that this is more infectious or more easily spread, but certainly, as you'll see here, the reduction in neutralizing antibody titers is pretty significant. So in this particular study, 8.6 times less neutralizing antibody titers. And in this study, which is similar to this one, about 6 times less neutralizing antibody titers. So we believe this to be primarily driven by the E484K. And I think, the most likely consequence of this is that immunity is probably going to go away faster. All the vaccines were able to stop replication of the virus still, which is great. But how long that immunity lasts with that lower neutralizing antibody titer sort of remains to be seen, and complicates that decision of, do we abandon the 2-dose series in an effort to vaccinate more people with 1 dose? Would that be enough against these variants? And we don't know that. So similar with Pfizer, 6.5 times less, and about 4 times less over here. So, this E484K seems to impact the neutralization potency significantly for these vaccines. And the P1 variant from Brazil carries a lot of the same mutations as the one that we just looked at. And so there aren't any specific data, but we anticipate similar decreases in neutralization potency with this variant. So real quickly, I just wanted to talk briefly about emerging mutations. So there is a variant called Cal20C, which originated in California. It has The prevalence of which has increased dramatically in the last 6 months. So in January, it represented 44% of the samples that were sequenced. And one of the mutations, the L452R, seems to act like the E484K, which helps evade antibodies. So that is concerning, and that's something that we're watching. And then, similarly in the UK, they found a new variant with the E484K. And so that's primarily our concern, is that reduction in neutralization potency, though with the CDC and the government taking more proactive approach with all the variants, perhaps we'll be able to have a better understanding of these. And so just to finish up, I want to reinforce that we still have work to do on vaccine hesitancy and education. As pharmacists and student pharmacists, we are the most underutilized and accessible healthcare professionals. So we can fill so many of those gaps. And this data suggests that although the number of people that are not likely to get it is decreasing, we should be making an effort to find most of these 18-19% that are in the somewhat likely and convincing them to get it. And as many as possible in this not likely group, to try and get them to really consider getting the vaccine. And I think that with the information we discussed today, you're going to be prepared to be able to do that. And so our work extends just beyond the general public. I've personally had incredibly smart providers come to me and talk about their concerns about getting the vaccine, et cetera. Looking in this particular study of emergency healthcare personnel, we do generally see a higher rate of acceptance, but you can see 22.3% of the nurses declined. And so we have, that's too many. And so we have a lot of work to do. And how to, I think this speaks to the fact that when we look at the reasons for declining it, safety is number one. But, their concerns are not really all that different than the concerns of the general public. And so all of these reasons that you see here, the safety, health conditions, previous diagnosis, pregnancy, ethical, and vaccine efficacy, we have talked about all those today. So you have the tools to make a dent in the amount of vaccine hesitancy out there. And I encourage you guys to try to do that. And so with that, I'll take any questions that you guys have.